Greetings, everyone. I would like to welcome you to the virtual symposium of the journals of the ILAE prizes. I would like to welcome everyone joining from anywhere around the world. My name is Samuel Wiebe. I am the president of the International League Against Epilepsy. And this symposium really is a celebration of excellence in epilepsy research. The International League Against Epilepsy, as you may know, has 3 peer-reviewed journals, which are at the very core of the League's professional and academic identity. Each journal has a different story, a different mandate. Epilepsia, which has been the official journal of the ILAE, has a history of 110 years when it became the official journal of the League, and now is a vehicle for publication of original research and large-scale official position papers of the League. Epilepsia Open, our newest journal, has an emphasis on ready and free access to published articles and to represent our constituency worldwide. And finally, Epileptic Disorders, which is the League's journal devoted to education and clinical practice, and which is closely aligned with the educational objectives and curriculum of the International League Against Epilepsy. Now, every year, the editorial teams of each of the 3 League journals identify from among hundreds of manuscripts, those that stand out in innovation and creativity, in methodological rigor, and in relevance to the field. And then, giving preference to early career researchers, 1 prize winner is selected for basic research and 1 for clinical research published in each of the journals Epilepsia and Epilepsia Open. And 1 prize is awarded for clinical and educational research published in epileptic disorders. The prize consists of live presentations like you will see today by the award recipients, usually done at a congress or symposium, this time done virtually, and this highlights the important work done by the recipients of the awards. It also has an ILAE Journal Award Certificate and a monetary component. These 5 journal prizes are of central importance to the League, because not only are they intended as recognition by the ILAE community of outstanding work done, but also because it is a stimulus for further basic and clinical research in epilepsy. A lot of thought and preparation goes into the journal awards and the symposium, and I would like to acknowledge the editorial teams of the ILAE journals for their work in selecting the journal's prize winners this year, and not least for their outstanding job in leading our journals. I would also like to thank the people that worked hard to put together this symposium, John Godman, chair of the ILAE Publications Council, and our ILAE team, especially Priscilla Schisler, Finola Quinn, and Dennis McAvoy. So today, the ILAE is proud to celebrate our journal prize winners this year, who are Lindsay Anderson from Australia, Benjamin Tolchin from the United States, J.C. Famader from the United States, Ana Luisa Coito from Switzerland, and Shang Ying from the United States. To all of you, I would like to express our gratitude for dedicating your skills and energy to the cause of epilepsy and for making us wiser through your important research. On behalf of our large ILAE community, I would like to congratulate each one of you on this important achievement and to wish you every success in your careers. We very much look forward to the presentation of your award-winning work during the symposium, and not least, we look forward to your continued research contributions in epilepsy in the coming years. And now I would like to turn it over to Dr. Mike Sperling, Editor-in-Chief of Epilepsia, to present the Epilepsia Awards.
Thank you very much, Dr. Wiebe. It's a pleasure to be here today. Today I have the pleasure of presenting 2 awards. Unfortunately, my co-editor-in-chief, Dr. Astrid Nellig, is unable to join us, but hopefully next year she will be with us again, and she and I together chose these awards, and she deserves full credit as well for choosing such wonderful papers. The first award that we're offering is an award to Lindsay Anderson. Dr. Anderson's paper was entitled Co-Administered Cannabidiol and Clobazam Preclinical Evidence for Both Pharmacodynamic and Pharmacokinetic Interactions. Dr. Anderson received her PhD in pharmacology from Vanderbilt University, where she was a participant in the Lambert Initiative for Cannabinoid Therapeutics Preclinical Research. And now she has moved to the University of Sydney, where she's a participant in the Lambert Initiative for the Cannabinoid Therapeutics Preclinical Research. She has focused her efforts on development of novel cannabis-based medicines for childhood epilepsy, and it is a great pleasure to present this award to Dr. Anderson. And we should have a picture of the award coming up now.
Right, thank you. Thank you very much to Epilepsia, the awards committee, and the International League Against Epilepsy. My co-authors and I are very honored to have received this award. Now you will see a pre-recording of my presentation, after which I will be available for questions. To everyone that has logged on, good morning, afternoon, or evening, depending on where you're located around the world. Thank you again to the International League Against Epilepsy for the opportunity to present today. Now, the background of this project actually starts with a bit of a story, and it begins with this little girl, Caitlin Lambert. Caitlin has Dravet syndrome and is treatment resistant to conventional anticonvulsants, but she achieved remarkable seizure control with medicinal cannabis. And this response to medicinal cannabis is what inspired her grandparents, Joy and Barry Lambert, to make an unprecedented donation to the University of Sydney to establish the Lambert Initiative for Cannabinoid Therapeutics. The Lambert Initiative was founded to unlock the medicinal potential of cannabis to treat a range of human conditions, but with a specific interest in intractable childhood epilepsy and Dravet syndrome. And it's my background in epilepsy research and genetic mouse models of epilepsy that I entered the picture. At the time that Lambert Initiative was established, I was at Northwestern developing and validating a preclinical screening pipeline in the SCN1A knockout mouse model of Dravet syndrome. Now, despite knowing next to nothing about medicinal cannabis, I took a leap of faith and moved to Australia to join the Lambert Initiative to use the screening platform from Northwestern to investigate developing cannabis-based medicines for childhood epilepsy. Now, just as I was moving to Australia, the results of an open-label trial using CBD for treatment-resistant epilepsy was published. And in this trial showed that clobazam co-medication predicted a greater seizure response for CBD. An earlier study showed a drug-drug interaction between CBD and clobazam, where a significant increase in plasma levels of N-desmethylclobazam, the active metabolite of clobazam, were seen with co-medication. If you consider the metabolic pathway for clobazam and N-desmethylclobazam, it's not that surprising that a drug-drug interaction was observed, because CBD has been shown to inhibit both CYP3A4 and CYP2C19. Now, needless to say, these results made me quite skeptical about the efficacy of CBD as an anticonvulsant, and I, like many in the epilepsy field, chalked its efficacy up to merely an interaction with clobazam, an opinion that was not very popular with the team of cannabinoid scientists that I had just joined. Fortunately, however, my new supervisor, Jonathan Arnold, welcomed my skepticism, and together we designed the study that's presented here today. To address the question, is the seizure reduction observed with CBD treatment the result of a direct anticonvulsant action of CBD, or merely the result of a drug-drug interaction whereby CBD augments clobazam exposure? So we aimed to illuminate the nature of the interaction between CBD and clobazam, characterizing first the pharmacokinetic interaction and then exploring its anticonvulsant effects using the SCN1A knockout mouse model. Now, roughly 80% of Dravet syndrome patients have a loss of function mutation in SCN1A, and heterozygous deletion of SCN1A in mice results in hyperthermia-induced seizures, spontaneous seizures, reduced survival, and behavioral deficits that faithfully replicate the phenotypes observed in patients. We then went on to interrogate a potential pharmacodynamic interaction between CBD and clobazam. But first, we investigated the pharmacokinetic interaction in vitro using microsomes containing recombinant human cytochrome P450 isoforms, CYP3A4 or CYP2C19. You're looking at the CYP3A4 mediated metabolism of clobazam on the left and CYP2C19 mediated metabolism of N-desmethylclobazam on the right. You can see that the product formation was inhibited with increasing concentrations of CBD, resulting in inhibitory Ki values for CBD presented here that are within the range of concentrations of CBD being achieved in the plasma of epilepsy patients. So next, we then explored whether this pharmacokinetic interaction in vitro translated to an in vivo interaction using wild-type mice co-treated with CBD and clobazam. And we generated concentration time profiles for both clobazam and endosmethylclobazam in plasma. And just at a glance, you can see significantly different pharmacokinetic profiles for when clobazam was administered in combination with CBD, the kind of bluish green curve, compared to when it was administered alone, the black curves. So CBD co-administration affects a multitude of the PK parameters of both clobazam and endosmethylclobazam, but it significantly increased the area under the curve of both, which is indicative of the exposure to each of the compounds. So increasing drug exposure is similar to what is observed in patients. So we next then wanted to ask, well, is this pharmacokinetic interaction translating into increased anticonvulsant action of CBD? And to address this, we used the SCN1A knockout mouse model, looking first at the effects on spontaneous seizures and survival. Here's a schematic of how these experiments were performed, with treatment beginning immediately after the induction of a febrile seizure. Treatment was administered through supplementation and chow and was maintained from postnatal day 18 out to postnatal day 30 in order to monitor survival. We quantified the spontaneous seizure frequency in this P19 to P21 window. Looking at the results of these treatments on spontaneous seizures, you can see that CBD at the dose we tested has no effect on spontaneous seizure frequency, whereas clobazam treatment was protective. Combination treatment was also protective, but not more so than clobazam treatment alone. Then looking at the effects on survival, you can see that our untreated controls have about a 50% survival out to postnatal day 30, the black line there. Treatment with either CBD or clobazam alone had no effect on survival. However, treatment with a combination of CBD and clobazam resulted in a significantly increased percentage of mice that survived to postnatal day 30, the blue dashed line there. So next, we then examine the effect of clobazam and CBD treatment on thermally induced seizures. And in this experimental paradigm, we increase the mouse body temperature until the mouse experiences a generalized tonic-clonic seizure. And an increase in the temperature at which mice exhibit a seizure is indicative of an anticonvulsant effect. Looking first at a dose response of clobazam in the presence and absence of CBD, the dose that we looked at with CBD here was 12 mg per kg, which is a sub-anticonvulsant dose. However, the plasma concentrations achieved with this dose are equivalent to those observed in patients. So if you look at the temperature at which mice exhibit a seizure, which is presented on the y-axis across these different treatments, you can see that clobazam dose dependently increases the temperature threshold, and that the presence of CBD in the gray bars has no added benefit, despite the fact that there is a pharmacokinetic interaction occurring here. So looking at the levels of clobazam in the plasma of these experimental mice, you can see that in the presence of CBD, there is a significant increase in the clobazam levels. Now, if we then repeated this experiment, but instead looked at an interaction using an anticonvulsant dose of CBD, or 100 mg per kg, you can see that the 100 mg per kg dose of CBD in combination with 1 mg per kg dose of clobazam, which is the anticonvulsant dose, that you see a greater increase in the temperature threshold than when either treatment was used alone. And so this was an interesting result for us because it suggested a pharmacodynamic interaction was occurring, whereby intrinsic anticonvulsant doses of both CBD and clobazam are necessary to see a greater anticonvulsant effect. We sought to explore this pharmacodynamic interaction further. So previous work from our group showed that CBD was a positive allosteric modulator of inhibitory GABA-A receptors. And since the mechanism of action of clobazam and endosmethylclobazam is via positive allosteric modulation of GABA receptors, we performed 2 electrode voltage clamp experiments on xenopus expressing GABA-A receptors. If we look first at concentration response curves of CBD and clobazam individually modulating GABA evoked currents, You can see clobazam in the black line with the open circles is more potent and efficacious than CBD, but CBD does indeed, this gray line, enhance receptor activation. When CBD is combined with clobazam or with N-desmethylclobazam in this bar here, the modulation of GABA is significantly enhanced compared to any of the treatments alone. So to summarize, co-treatment of CBD and clobazam had greater anticonvulsant efficacy, but only when an anticonvulsant dose of CBD was used. A sub-anticonvulsant dose of CBD did not potentiate the effects of clobazam, despite the presence of a pharmacokinetic interaction. And we presented a novel pharmacodynamic interaction whereby CBD and clobazam together enhanced GABA-A receptor activation. Collectively, these results suggest to us that both pharmacodynamic and pharmacokinetic interactions are likely contributing to the anticonvulsant efficacy of CBD and clobazam co-treatment. And further support for CBD having intrinsic anticonvulsant properties, independent of clobazam, has also been demonstrated clinically in these articles. Now, with all of this data, I have decided to change my tune on the anticonvulsant efficacy of CBD. I have seen the utility, and I don't chalk its efficacy up to just a pharmacokinetic interaction with clobazam. Now, extending this research into our current experiments, we're investigating the effect of CBD in combination with THC. A previous study in our group examined cannabinoid profiles of artisanal cannabis products being used in the community and found that most contained a small amount of THC. So we wanted to see whether the presence of THC contributed to this perceived anticonvulsant effect. And interestingly, if we look at hyperthermia-induced seizures, a low-dose THC, 0.1 mg per kg, presented here in this green bar as anticonvulsant, is significantly increased the temperature threshold. But when combined with a sub-anticonvulsant dose of CBD, the 12 mg per kg dose, a potentiated anticonvulsant effect is observed with this orangish-reddish bar, where the temperature threshold was significantly greater than either of the monotherapies. However, when CBD and THC were administered in combination, survival of SCN1A knockout mice was significantly worse. This report that characterized the cannabis extracts being used out in the community also showed that the artisanal cannabis products had diverse cannabinoid profiles, which is not surprising since cannabis contains over 120 different cannabinoids. So we've also been mining the cannabis plant for other anticonvulsant cannabinoids in an effort to find the next generation cannabis-based anticonvulsant. So we've screened a handful of these against hyperthermia-induced seizures and have found some that do increase the temperature threshold: CBDV, CBDVA, CBGA, CBGVA. Additionally, we found one that was proconvulsant. THCV reduced the temperature threshold. So this is a great start for looking at cannabinoids in the cannabis plant beyond CBD that may have anticonvulsant potential. So just to quickly wrap up, I'd like to say thank you to our philanthropists, Joy and Barry Lambert, without whom this work would not have been possible. I'd like to acknowledge the Greater Lambert Initiative team, but specifically my supervisor, Jonathan Arnold, and my co-authors, which are pictured here.
Thank you very much, Dr. Anderson. It was a very interesting and informative talk. We will now be open for questions from our audience. And you can type questions in the Q&A box at the bottom of your screen or the top of your screen, depending upon your platform. While we're waiting for our audience to offer some questions, I will ask you one myself, and that would be an extrapolation to clinical medicine for all of us, which is obviously where you're headed. And that is that there is some controversy within the neurological treatment community as to the use of co-medication. Is there really an advantage of using two different mechanisms, using multiple drugs as opposed to using monotherapy, given the side effect profile? It seems here that you're targeting the GABA receptor in two spots, perhaps. And I was wondering what your thoughts are in terms of approaching treatment that way, because we can think of other drugs that, for example, hit the sodium channel in two different ways.
Yeah, I think the finding where CBD interacted at the GABA receptor in combination with clobazam was interesting, and I think that's probably that pharmacodynamic interaction is contributing to its efficacy. But I think CBD is a bit of an interesting compound because it targets a lot of other receptors. So it inhibits GPR55, it has action at 5-HT1A. And so I think that while it has this pharmacokinetic interaction with clobazam, it has a pharmacodynamic at the GABA-A receptors, we also have these kind of parallel complementary pathways that could be contributing to its anticonvulsant efficacy as well. So I actually think it's a bit of a benefit to have more than a combination therapy rather than the monotherapy, because you can target these different pathways.
Thank you. Yeah, it certainly puts a perspective on clinical practice, and I think it's very valuable research. We have 3 questions so far. The first from Jonathan Carl Arnold says, "Bravo, Lindsay. Dick Lindhout, elegant study design. Delara Bachechi, I apologize for mispronouncing your name. Great talk, Lindsay." And Samuel Bannister, "Nice work, Lindsay. Well presented." Those seem to be our questions. I think you did it very well. And perhaps what we can do is, rather than running late, and more nice work, Lindsay, well presented, great talk from others as well. So Priscilla Schisler would like to answer this question live. So there's a live question for us.
Oh, the question, do you think the interaction with CBD and THC is PK or PD? Is that what you're?
That's what someone wrote, yes.
Yeah, okay. So, I mean, it's actually, you only just saw a snapshot of that study. So there's definitely a PK interaction occurring there. Both plasma levels of CBD and THC increase when they're dosed in combination. However, if you dose with or repeat the study with lower doses to account for that PK interaction, you still see the impaired survival. So I think it's a combination here, once again, of a PK and a PD interaction occurring.
Thank you. Okay, well, if there are no further questions, I think we should move on. So thank you very much. I'm sorry, there's one other question from Bill Tatum. With more than 120 cannabinoids, did you find any compounds that had proconvulsant properties in the hypothermia mouse model, which should be avoided?
Yes, we haven't tested all 120. We're working our way through them. And we're also looking at using full spectrum extracts. So that's something else we're working on. But yes, we did find THCV was proconvulsant in the mouse model. So I would suggest that that's probably contraindicated for Dravet syndrome.
Thank you. Okay, well, thank you very much. So we've had some questions. Congratulations again. A wonderful paper, wonderful work, and I'm sure you have a great career ahead of you. We will move on to our next prize winner. Priscilla, if you could put up the slide for Dr. Tolchin, I would appreciate it. So our next prize winner is Dr. Benjamin Tolchin. Dr. Tolchin is being awarded the Epilepsy Clinical Science Prize for best paper by a relatively young investigator. And the criteria for the Epilepsy Awards are the people who win them must be within 8 years of finishing training. You don't have to be young, you just have to be within 8 years of training, I guess. And Dr. Tolchin has won this. He attended medical school at Harvard University, performed his neurology residency at Columbia University, and then did clinical neurophysiology and epilepsy fellowships at Brigham and Women's Hospital, Harvard Medical School. Dr. Tolchin is now an assistant professor of neurology at the Yale School of Medicine and also at the Veterans Administration, Connecticut Healthcare. He has a clinical and research focus on psychogenic seizures and other functional disorders, and is awarded this prize for his study published in Epilepsia on It's called Randomized Controlled Trial of Motivational Interviewing for Psychogenic Non-Epileptic Seizures. And our next slide is the award. So congratulations to Dr. Tolchin for winning the prize for the best paper of the year in epilepsy.
Thanks so much, Dr. Sperling, and thanks to the ILAE and to the study teams and mentors at Brigham and Women's Hospital and at Yale, and especially thanks to the patients whose participation made the research possible. We're going to do a recorded version of the talk, and then I'll be available afterwards if you have any questions. Thank you. Thanks very much for having me. My name is Benjamin Tolchin from Yale School of Medicine, and I'll be speaking to you about a randomized controlled trial of motivational interviewing for psychogenic non-epileptic seizures. So what are psychogenic seizures? These are paroxysmal events that involve involuntary movements and/or alterations in consciousness that are thought to be caused by psychological factors. Unlike epileptic seizures, with which they can easily be confused, psychogenic seizures are not associated with epileptiform discharges on EEG. And psychogenic seizures are a form of functional neurological disorder in the Diagnostic and Statistical Manual 5th edition, and are also known as functional seizures or dissociative seizures, although I'll be using the term psychogenic seizures throughout this discussion. There's a growing body of evidence showing that psychotherapy, and particularly cognitive behavioral therapy, is effective in improving quality of life, psychosocial function, and seizure-free periods for patients with psychogenic seizures. In particular, there is the CODES trial, a large multi-site, fully powered randomized controlled trial of cognitive behavioral therapy showing it to be effective for patients with psychogenic seizures, coming out in the Lancet Psychiatry this month. However, our prior studies show that the majority of patients diagnosed with psychogenic seizures do not complete any form of psychotherapy. The survival curve on the right, previously published in Epilepsia, shows that approximately 60% of patients diagnosed with psychogenic seizures drop out of psychiatric follow-up within 3 months, and 86% of patients drop out of psychiatric follow-up within 17 months of diagnosis. In addition, our previous work has shown that patients who are not adherent with psychotherapy have worse quality of life, worse frequency of seizures, and worse emergency department utilization when compared to patients who are adherent with psychotherapy. We therefore conducted a randomized controlled trial of motivational interviewing as an intervention to enhance adherence with psychotherapy among patients with psychogenic seizures. So participants were recruited in an epilepsy monitoring unit, in an epilepsy clinic, or in a neuropsychiatry clinic after they were diagnosed with psychogenic seizures using video EEG monitoring, including the capture of all typical episodes on video EEG. All participants were referred for psychotherapy, and all psychotherapists were contacted by a neuropsychiatrist with treatment recommendations. But participants were randomized to receive either an informational session with 30 minutes of motivational interviewing, or the informational session alone. And this intervention was delivered between the time of diagnosis and the referral to psychotherapy. Motivational interviewing, the study intervention, is a patient-centered form of counseling that has been shown to be effective in addressing the common problem of ambivalence about behavior change. Motivational interviewing makes use of 4 overlapping processes. The first process is engaging, in which the motivational interviewer establishes an open, empathic relationship with the patient and helps to explore their experience and perception of their psychogenic seizures. In the second process, focusing, the interviewer narrows the conversation on a particular target behavior change, in this case, adherence to and engagement with psychotherapy for the treatment of psychogenic seizures. In the third process, or evoking, the interviewer uses reflective listening techniques and other motivational interviewing techniques to elicit the participants' reasons and needs for engaging in psychotherapy for the treatment of psychogenic seizures. And in the fourth process, or planning, the interviewer facilitates and scaffolds the participants' development of their own plans for engaging in psychotherapy to treat psychogenic seizures. In terms of assessments, participants in our study were evaluated at baseline and then at 16-week follow-up for demographics and also for the primary and secondary outcomes. In terms of the primary outcome, this was the number of psychotherapy sessions attended over 16 weeks. Participants were dichotomized as adherent if they had attended 8 or more psychotherapy sessions over 16 weeks, and non-adherent if they had attended less than 8 sessions over 16 weeks. The cutoff of 8 psychotherapy sessions was derived based on review of preliminary data from a prior cohort of patients, as well as from review of the literature regarding psychotherapeutic treatments of psychogenic seizures and other disorders. In terms of secondary outcomes, participants were assessed for weekly frequency of their psychogenic seizures, both at baseline and at 16-week follow-up, and for quality of life as measured by the QALY-10 instrument, which is a validated 40-point scale for measuring quality of life in patients with seizures. Participants were also evaluated for emergency department visits per month at baseline and at 16 weeks follow-up. Overall, we screened 67 potential participants and enrolled and randomized 60 participants. Of these, 31 were randomized to receive psychotherapy alone, which was the control arm of the study, and 29 were randomized to receive psychotherapy preceded by motivational interviewing, or MI. This was the study arm. Of the control patients receiving psychotherapy alone, 29 were included in the final analysis, and of the motivational interviewing arm, 26 participants were included in the final analysis. The baseline characteristics of the 2 groups of participants were well balanced. Of note, participants were aged approximately 40 years on average, with an average age of onset of psychogenic seizures of approximately 1 year less. So participants had, on average, been suffering from psychogenic seizures for just under 1 year at the time of diagnosis. The overwhelming majority of participants were female, and participants were quite psychiatrically ill. Approximately 95% of participants had at least one additional psychiatric comorbidity in addition to psychogenic seizures, and approximately 60% of participants had a history of some form of abuse. The median frequency of psychogenic seizures was just over 3 psychogenic seizures per week. In terms of the primary and secondary outcomes, participants randomized to receive motivational interviewing prior to psychotherapy had approximately 65% adherence with psychotherapy, compared with only 31% adherence to psychotherapy among participants randomized to receive psychotherapy alone. This was a statistically significant difference, with an absolute risk reduction of 34% and a number needed to treat of 2.9, meaning that for every 2.9 patients with psychogenic seizures treated with motivational interviewing, you would expect 1 to transition from non-adherent to adherent with psychotherapy. In terms of secondary outcomes, participants randomized to receive motivational interviewing plus psychotherapy saw a 76% reduction in the frequency of psychogenic seizures as compared to a 35% reduction in the frequency of psychogenic seizures among those participants randomized to receive psychotherapy alone. This, again, was a statistically significant difference with a Cohen's d of 0.59, which is consistent with a moderate effect size. In terms of psychogenic seizure freedom, 31% of participants randomized to receive motivational interviewing plus psychotherapy were free of psychogenic seizures at follow-up, as compared to 11% of patients randomized to receive psychotherapy alone, but this was not a statistically significant difference. In terms of quality of life, participants randomized to receive motivational interviewing plus psychotherapy saw approximately a 7-point improvement in their quality of life as measured on the 40-point Quality 10 scale. And this would be compared to a 2-point improvement for patients randomized to receive psychotherapy alone. This, again, was a statistically significant difference with a Cohen's d of 0.60, which is, again, consistent with a moderate effect size. There was not a statistically significant difference in the change in monthly emergency department visits. From these results, we conclude that motivational interviewing is an effective intervention for the common problem of non-adherence with psychotherapy among patients with psychogenic seizures, and that motivational interviewing as a prelude to psychotherapy improves frequency of psychogenic seizures and quality of life. We also feel that these findings highlight the importance of improved clinician-patient communication and of close collaboration between neurologists and psychotherapists in the treatment of functional neurological disorders. We would recommend that motivational interviewing should be tested to address non-adherence with treatment in other disorders where ambivalence and non-adherence is a common problem, and that would include functional neurological disorders and epilepsy. While our study shows extremely promising results for in-person, face-to-face treatment of psychogenic seizures, the majority of patients with psychogenic seizures are either not able to access face-to-face psychotherapy or can access such treatment only after a prolonged delay of 6 to 12 months. Therefore, we are currently developing and testing the iStare app, an iOS-based mobile application which can be used on iPhones, iPads, and other iOS-capable devices, and which uses motivational interviewing and cognitive behavioral therapy methods to teach users skills for managing psychogenic seizures. Finally, I'd like to thank very much my mentors at Brigham and Women's Hospital and at Yale School of Medicine for their guidance and support. In particular, Larry Hirsch, Steve Martino, Hal Blumenfeld, Hamada Altalib, Gaston Bezlet, and Barbara Duretsky. I'd also like to thank the American Academy of Neurology and the American Brain Foundation, the Veterans Health Administration, and the Swabilius Foundation for their generous funding. And I'd like to thank particularly my family, Dorothy, Natalie, and Zach, for their love and patience. Thanks so much for your attention, and I'll be happy to take any questions.
Thank you very much, Dr. Tolchin. Excellent talk, very interesting. And we have some questions that have been posed or comments. One comment is, thank you for talk and good work. Can we please remove the word seizures and change the nomenclature to non-epileptic events or episodes, which is a comment that's been made before by other people. And then the question also poses that overall healthcare utilization reduce in your sample.
Yeah, so those are two great points. In terms of changing the terminology, there's going to be a discussion and debate actually at this year's American Epilepsy Society in the non-epileptic seizures special interest group about trying to determine one unified terminology to use for this disorder. There are a lot of different ideas about the best terminology, and I think it's critical that we come to a single unified terminology, and there are a lot of considerations to be taken into account. So I'd encourage you to participate in that conversation at the annual meeting. In terms of overall healthcare utilization, we looked at emergency department utilization and clinic visits, and we did not see a statistically significant difference there. I think in large part because our sample size was too small for that issue, but larger studies of utilization after the diagnosis of psychogenic seizures have been conducted and has shown that healthcare resource utilization and healthcare costs have decreased significantly after the diagnosis and after the implementation of psychotherapy.
Thank you. Another question here. Did you find a particular semiology, convulsive or non-convulsive, for event frequency that was especially amenable to the motivational interviewing and psychotherapy?
No, we did not. So we looked at motor versus non-motor psychogenic seizures, and we did not see a difference in the response based on the semiology of motor versus non-motor.
Thank you. Another question, which I know the answer to, the answer is you, but who in your group or the study performed the motivational interview? And I remember from your paper that it was you who did it. So how do we learn to do this? So what, in terms of the next step, extending it?
Yeah. So in terms of learning motivational interviewing, there are a lot of different options. For me, the best option was a motivational interviewing workbook, which is available on Amazon, is available as a PDF on Kindle. There are also workshops that are available. There are online and in-person workshops that range from a couple of hours to a couple of days. And I think that's a really great way of learning the basic techniques. The one thing that I would really recommend for anybody who wants to learn motivational interviewing and really improve your skill at it is to participate in a study group. So many institutions, many hospitals, many psychiatric groups, because motivational interviewing is so widely used today, will run peer study groups where you can record motivational interviewing sessions and get feedback. And I think that's a really wonderful way to develop your skills if it's something that you're really interested in doing.
Okay, and there are several compliments to you as well from attendees, so I'll pass those along. It did very well. I'm trying to think of what, and I suppose the only other question I'll ask is how can neurologists and mental health care clinicians more closely collaborate to treat people with these psychogenic non-epileptic seizures or attacks and other functional disorders? That will be our last question.
So I think there are a number of ways that neurologists and mental health clinicians can collaborate. I think in some cases it is possible to build a center that specializes in the treatment of functional neurologic disorders that includes both neurologists, psychotherapists, and psychiatrists, as well as social workers and other specialists. And that's a really wonderful resource if that's available in your community. In many communities, that level of resource is not available. And I think in those cases, it's really essential that individual neurologists and psychotherapists make an effort to reach out and communicate with each other, not just sharing notes, but actually speaking on the phone. One thing that I've found is critical in treating patients with functional neurologic disorders, including psychogenic seizures, is calling the psychotherapist to whom I'm referring the patient, letting the psychotherapist know verbally how the diagnosis was made, our level of confidence in the diagnosis, and recommendations about treatment, including published psychotherapy regimens that are available. I found that greatly increases the comfort of the psychotherapist and the efficacy of the psychotherapy.
Okay. And do your colleagues have anything to add to that who are sitting next to you or not?
You guys have anything to say?
Okay, well, thank you very much then. Congratulations again on the prize. And I'd now like to turn this over for the next stage for the Epilepsia Open prizes to Dr. Aristea Galanopoulou, one of the co-editors-in-chief of Epilepsia Open.
Thank you very much, Mike, and good morning to everybody. It is my great pleasure to represent my co-editor-in-chief, Dong Zhu, and also the whole editorial board who were very much involved in the selection of the prizes for the Epilepsia Open. Sam described the process of the selection, which is extensive, and we review a large number of articles that are submitted from young investigators for the best meritorious article that has been published the year before. And this year, it is my great pleasure to introduce first the 2020 Epilepsia Open Basic Science Award. Which I think I'm sharing the wrong screen, so let me just. And this year we selected a paper that was published by Jesse Palmater. Jesse received a PhD in entomology from the University of Wisconsin in Madison in 2015. And it was a sort of a natural development for him to switch from entomology to postdoctoral training in epilepsy because, as he quotes in his interview, the brain is very much like a forest. So he was attracted and he stayed at the University of Wisconsin in Madison along with Matthew Jones, and that's where the article that he will be presenting today was produced, and it has to do with an automated machine learning based detection algorithm for spike wave discharges in a mouse model of absence epilepsy. There is not many people, I would say, that would call 2020 the best year of their lives, but it is not only that Jesse received this award, prestigious award from Epilepsia Open for the Basic Science Prize, but also he's a first-time dad and he's very proud because his first son was born a few days ago. So without much ado, I would like to congratulate Jesse and give him the forum to present his work.
Thank you so much, Aristea, and my collaborators and myself really want to thank ILAE for the award. We really appreciate being honored. Right now, we will play the pre-recorded talk, and I'll be available afterwards for questions. Thank you to ILAE for the opportunity to highlight our research here today, and thanks so much to everyone for attending this virtual symposium. Today I'll present my work, an automated machine learning-based detection algorithm for spike wave discharges in a mouse model of absence epilepsy. Absence seizures are most commonly associated with childhood absence epilepsy. It's estimated that approximately 50,000 children have freezing staring fits lasting for 10 to 60 seconds. Individuals can have up to 200 seizures a day, and they're quite disruptive to the child. They can cause problems with learning and problems with development of social interactions. I'd encourage everyone to spend some time seeking out videos of children with absence epilepsy in order to better understand the kind of impact that these seizures can have on a child's life. In our lab, we study absence epilepsy in mouse models, and in mouse models and humans alike, the spike and wave discharge is the electrographic or EEG activity associated with the disease. This image shows a series of spike and wave discharges generalized across 4 EEG traces from a mouse brain. Notice how in the gray trace towards the bottom, the EMG trace, which is indicative of mouse movement, shows periods of quiescence concurrent with the spike and wave discharges. The bottom trace shows a blow-up view of one set of spike and wave discharges. This recording and all the data presented in this talk come from the C57BL6 mouse model with a knock-in R43Q mutation, which causes absence epilepsy. In mice, what defines a spike and wave discharge is this characteristic increase in power around 6 Hertz. We can see that strong power increase here in the wavelet decomposition of the above signal for the first 2 kind of rhythmic events here. We also see kind of strong rhythmic increases in power in higher frequency bands. In fact, several papers have focused more on the harmonics of this 6 Hertz signal rather than just the 6 Hertz frequency itself. But generally, we can see this fairly characteristic fingerprint of a spike and wave discharge. And while we have this characteristic fingerprint image of the spike and wave discharges, and we can identify particular power spectra and rhythms associated with this fingerprint, the next question becomes, how do we decide which events are spiking wave discharges and which are not? The events on this screen are pretty clear, but there's more ambiguous events to deal with that we'll get to in the next slide. So here are 8 putative spiking wave discharge events identified by the first stage of our algorithm. We identified putative spike and wave discharge events by first finding all peaks in the signal greater than 3 standard deviations from the mean signal. We then took all events that had a series of peaks within 3 to 11 hertz. This method gives us kind of gets us in the ballpark and catches almost all events that humans might identify as spiking wave discharges, but also produces an abundance of events that don't appear to be absence epilepsy related. So the next step is to filter between yes, spiking wave discharge, and no, this is not a spiking wave discharge. In order to do this, we set up a little program to allow us to present putative events to humans in a controlled fashion. So 4 human scorers experienced at identifying spiking wave discharges filtered through 2,500 events and simply deciding yes or no for each event. We then plotted several features, the mean, standard deviation, and maximum power calculated from 2 bands, the 4.4 to 8.2 hertz and 17.6 to 32.8 hertz bands of the wavelet decomposition fingerprint that was most prominent. These features were most prominent during strong examples of spiking wave discharges. We color-coded each event based on the agreement of the human scorers. So the green points here are disagreement, or at least one dissenting opinion among the group. Blue shows events that were agreed upon as not being a spiking wave discharge, and red shows events that were agreed upon as a spiking wave discharge. The take-home from these plots is that for any pair of features, each of the plots with individual data points here are the paired sets of features, or from every single feature represented by the histograms on the diagonal, the space that defines agreement, a yes or no, or a disagreement is not clearly defined. For the purposes of this talk, we'll focus on a pair of features shown in the lower left corner of this figure, and so the features that we're interested in here are the max of the 17.6 to 32.8 hertz band plotted against the mean of the 4.4 to 8.2 hertz band. So for this feature space, and in all 4 plots on the right, we can kind of take a closer look at each of the human scores' individual responses, and we can see just how variable the expert human scores are in classifying these putative events. For example, score 1 is very conservative in assigning a yes to an event, while score 4 is quite liberal in assigning events as spiking wave discharges. For all of these scores, you can see that there is a range of heavily overlapping yes and no classifications, kind of this band diagonal through these plots, where there's overlapping red and blue. It's true that if we were to able to plot these features in more multidimensional space and plot more features at once, this muddy, fuzzy space in the middle would become a little more discrete. However, there still wouldn't be a perfectly clear boundary because there's actually a component of uncertainty associated with each scorer's assignment of a given event. And so in order to characterize the within scorer variability, we presented 50 of these events in repeat 10 times each shuffled throughout the data set. So scorers were unaware that these events were repeated. And on the top here, you can see 8 of the 50 events we presented to human scorers. So now we're armed with information on the inter-rater reliability for a large number of events, that's 2,500, and we have higher resolution information on the inter-rater reliability and the intra-rater reliability for a subset of 50 events. And we use this information to build a support vector machine, the output of which is shown in the upper right panel. We use this support vector machine to classify events. This not only provides a yes or no classification for each event, but we can use the distance to the decision boundary as the type of confidence measure associated with the classifications. So we get a yes or no from the algorithm, as well as a measure indicative of the likelihood that this is a spiking wave discharge event or a confident not spiking wave discharge event. And indeed, the distance to the decision boundary directly correlates with the inter-rater reliability information gathered from our human scores. You can see that in the lower right plot. It's important to note that we tried other more traditional types of classification tools, including k-means, but those produced decision boundaries that were too sharp and that didn't accurately represent the types of decisions that humans make for these more ambiguous events. For example, notice that event number 3 above and in the upper right panel. I've not shown the data here, but you can find it in the manuscript if you're interested. This event is the type of event that a human scorer would confidently identify as a spiking wave discharge, but that falls in the not a spiking wave discharge on that side of the line when classified with k-means. And so this is an example of these classification methods that are a little bit more simplistic and don't quite have as much complexity as the support vector machine. Oftentimes just draws this sharp line, which is not quite the way that humans would make decisions about these events. So with the algorithm, we kind of put it to use here so you can see how it might be utilized in the real world. So the top panel is a hypnogram showing sleep-wake patterns of a mouse. Mice cycle from wake, the cyan color periods, to periods of sleep, which are color-coded in green with small bouts of REM sleep, magenta. And I'm introducing sleep here because we know that many epilepsies are related to sleep in some way. And the physiology of sleep in mice is easy to characterize from EEG recordings. So perhaps we can show a relationship between spike and wave discharges and sleep transitions. In the middle panel, we show where putative spike and wave discharge events occur throughout this record. And the height of each spike and wave discharge lollipop here provides the confidence in scoring. So that distance to nearest support vector score, where a higher positive amplitude is a more confident spike and wave discharge, and a more negative amplitude is a more confident not spike and wave discharge event. The panel on the bottom provides kind of the average number of spike and wave discharges in each hour timed in over the course of the recording. And it does appear like there might be some relationship between sleep bouts and spike and wave discharge occurrence. If we take a closer look at the average EEG activity around each putative event, we can find a relationship between the events and changes in delta, theta, sigma, and gamma power. For example, in the lower left plot, if you look at the red trace, which is indicative of strong examples of spike and wave discharges, you can see that just prior to an event, delta power tended to be low, and that after an event, delta power tended to increase, indicating that animals were more likely to be awake just prior to a spike and wave discharge, and that they are transitioning into sleep after an event. Importantly, the magnitude of this relationship changes depending on the confidence of spike and wave discharge. Of course, these data are preliminary, and while we have done a bit more work on this that I'm not presenting here today, we have a lot more work to do, but these data are very promising, and we're excited about them. And we hope to kind of continue along this path. We also have some other work looking at interictal spikes, and we take a very similar probabilistic approach to classifying these events. So if you do get a chance to take a look at that, that's a PLOS One paper that came out, I believe, in 2019, Fameter et al. And thank you so much for your time today, and we really appreciate the chance to promote our work. Before I go, I just want to give some special thanks to some individuals and funding sources that made this work possible. Kyle Mangan and Aaron Nelson collected data. Kyle and Eli Wallace also did some scoring for us, both manual scoring of spike and wave discharges, and Eli did some sleep scoring. Rebecca Willett helped with kind of conceptualization of some of our statistical analysis. Rachel Bergstrom read several drafts of the manuscript. Steve Petru initially developed our 43Q model, a knock-in model of Abson's epilepsy. I'd like to thank ILAE again, and of course our funding at NIH and the US Department of Defense. Thank you so much, and I will be available for questions.
Thank you very much, Jesse. That was a terrific presentation. I would like to open it for questions. We have already one question by Jean Gottman. The question is, given the high inter-rater variability, should we ignore the human rater and use a formal definition of the event and declare as event whatever fulfills the formal definition?
Yeah, I think that's a great question. I don't think that we should totally ignore the human at this point, because it's the human variability that allowed us to kind of develop this algorithm, and the understanding of kind of the variability within each spike and wave discharge event is kind of characterized very well by the human assessments of what an event is and what it isn't. And then we were able to thankfully show that that variability is related to physiology in the animals, but we have a lot more work to do before we can just slap a definition on a spike and wave discharge event. For example, the program that we wrote, it does work really well in the models that we used in our paper. When we try and generalize it to other models, there's still a bit of training that needs to happen for the algorithm, and so we kind of still need this human input. And before we have exact physiological markers that we can use to train the algorithm, we can't necessarily move away from the human scoring. But I do think we're hopefully on a pathway to be able to identify these specific characteristics that can then be a more formal definition. And then we can watch, hopefully, how these characteristics change under different interventions and things like that. So I think that's a great question, though.
It gives actually a prelude to another question that I had. Have you collected any comments from the raters about what aspects made them more confident that this is a spike wave, and what aspects tip them towards calling them non-spike wave discharges, and how could those help you improve the algorithm in terms of differentiating from patterns that are not necessarily spike wave discharges?
Yeah, that's a good question too. Probably the number one comment that's made by a human rater that has a clinical background is that the spike and wave discharge has to stand out of the background. And interestingly, in these mouse models, they don't stand out of the background of the EEG as much as the spike and wave discharge do in human patients. And who knows exactly why that is. But it's a lot of the features that individuals choose, or that the guidance that they're using to select spike and wave discharges, are really difficult to verbalize in a lot of situations. And so I think that this is also kind of a good use of papers like this and studies like this, is to kind of try and pinpoint features of these events that are related to kind of some of the human characteristics in how they're choosing to score, because it's when you ask people, it's really hard to define.
We also have another question by Dick Lindout. How would you respond to the following two statements? Number one, this is a study of how raters categorize and may help to improve understanding how we work, versus two, this study may eventually evolve into a tool that rates better than the human raters.
I would say really it's both. I would say my initial goal in writing this algorithm was to help with my own classification of spike and wave discharge events. I don't feel like I'm very good at it because, for one reason, I just generally think everything is a spike and wave discharge. So it's good to have a filter for me. And then we realized that, there's all these differing opinions about what a spike and wave discharge is, and really ground truth for what a spike and wave discharge is should go back to kind of this clinical, the physiology of the animal, the physiology of the human. And so it's very possible, and I think there will be a point in time in the future when a computer is better at scoring these events, and is the tool, we're developing this tool, that kind of goes along with John's question, but for now, this is a tool to help human raters better understand what they're scoring. So it's both.
Great. And the very last question, which I think probably is going to come out from your future work, Diana Middleton, firstly, congratulations on becoming a father. Has anyone noticed additional biomarkers to help the algorithm?
Not to my knowledge. There are some additional markers that we focused on when developing the paper, not other biomarkers, but just kind of features from the EEG that we considered. And none of them really helped improve the spike and wave discharge detection. However, there are certainly other physiological features going on within the EEG and the EMG signal that I think we could incorporate in the future, but we have not done that yet.
Terrific. Thank you very much, Jesse. It was a terrific opportunity to meet you and also learn about your work. Thank you.
Thank you so much.
And I would like to switch to the 2020 Epilepsia Open Clinical Science Prize, which this year it is, and I hope I'm gonna share the right part of my screen. And this year, the Epilepsy Open Clinical Science Prize was awarded to Ana Luisa Luis Coito from Portugal. Ana received a BSc and Masters of Science in Biomedical Engineering from the University of Lisbon. She did her PhD in Neuroscience at the University of Geneva, completed in 2016, and then continued for a postdoctoral research fellowship at the University of Geneva in Switzerland, probably finishing around the time that she became a full-time mom, which also presents the challenges that many of you young investigators have in building careers while building also families. What we will listen today is the award-winning article that her group published on interictal epileptogenic zone localization in patients with focal epilepsy using electrical source imaging and directed functional connectivity from low density EEG. And it is my great pleasure to present the certificate of award to Ana Luisa Coito, and I'm looking forward to hearing her present the work. Congratulations, Ana.
Thank you so much. I'm really honored to have received this prize. And I would like also to thank all the co-authors of this study. And now the pre-recorded presentation of this talk will be played, and I will be then available for questions. Hi, so my talk is about electrical source imaging and functional connectivity in routine clinical EEG. Epilepsy surgery in focal epilepsy patients that are refractory to antiepileptic drugs can be a very efficient treatment. And therefore, the accurate location of the epileptogenic zone to be removed by surgery is crucial. And epileptogenic zone estimation is often difficult, and it requires the concordant results of several per-surgical evaluation techniques. So the development of new non-invasive interictal diagnostic and prognostic markers is important. And because seizures cannot always be recorded during clinical evaluation, the consideration of interictal activity is really relevant. However, even when the several per-surgical evaluation techniques are concordant and epileptogenic zone estimation seems to be clear, epilepsy surgery does not always lead to seizure freedom. And this could be because epileptic activity involves widespread brain networks rather than single sources, which leads to the concept of epileptic networks. So the way brain regions communicate is a very important topic in epilepsy. And the better characterization of these networks, so namely by a better knowledge of the organization and dynamics of the networks, can be an important diagnostic and prognostic value in epilepsy surgery candidates. And to study the interactions between these networks, we use the concept of functional connectivity. So we use functional connectivity measures that study how the activity in one brain region influences the activity on another or of another. And The EEG has a high temporal resolution, and therefore it turns it very suitable to study the dynamic and fast occurring processes in the brain, namely interictal spikes. And therefore it allows us to analyze the dynamic behavior of epileptic networks. However, the EEG per se does not indicate the location of the active neuronal populations. And for that, we have to perform ESI, which in order to reconstruct the sources in the brain that give rise to what we see in the EEG. And for that, we need to compute the forward model and the inverse solution. So the forward model describes how the electrical currents in the brain give rise to the scalp potentials and depends on the use of an appropriate head model, which considers and takes into account the electrical propagation of the electrical fields across the several head tissues. And then the inverse solution, once we have the forward model and the scalp potentials, we can compute the inverse solution. And there are several inverse solution methods. Here we used a distributed linear inverse solution, which considers a 3D grid of solution points that are placed in the gray matter, so they have fixed positions. So ESI has been shown to have a high accuracy and reliability for localization of the irritative zone during interictal spikes using high-density EEG, and even more than other perceptual evaluation techniques that are already currently used. So brain connectivity aims to analyze or to study how different brain regions communicate and interact, and functional connectivity measures the statistical dependencies between signals of different neuronal populations. And depending on whether these dependencies are assumed to be instantaneous or to reflect a dynamic process, we can further subdivide in directed or undirected functional connectivity. So here we considered a measure of directed functional connectivity in order to study the influence that one region exerts onto another, and therefore to depict directional relationships. And for this, we use the concept of branch causality. And therefore, we can study the information flow between brain regions and more specifically the outflows. So which regions are the big drivers of the information flow in the network? So the state-of-the-art ESI for epilepsy, it's in presurgical evaluation, is high-density EEG, and on the other hand, the high-density EEG studies have shown that studying directed functional connectivity can be very useful for depicting the main drivers of epileptic activity. However, the clinical utility of these measures is limited by the availability of high-density EEG in clinical settings worldwide. So in this study, and it was a multi-center study between Aarau and Geneva, and we considered, so in focal epilepsy patients and considering interictal spikes taken from the clinical or low-density EEG, we wanted to assess whether electrical source imaging and directed functional connectivity would be also reliable to estimate epileptogenic zone. So by epileptogenic zone, we mean the volume that was removed by surgery in postoperative seizure-free patients, or the cortical lesion concordant with electroclinical semiology. So first of all, we searched in the database of both hospitals, of the Cantonal Hospital of Aarau and the University Hospital of Geneva, for focal epilepsy patients with a well-characterized epileptogenic zone, and this either by considering the focal lesion or by invasive confirmation, so by surgery or intracranial EEG. and patients that had at least 10 interictal spikes in the clinical EEG. So 34 patients fulfilled this criteria, and 20 of which were temporal lobe epilepsy patients and 14 extratemporal lobe epilepsy. We then marked interictal spikes and pre-processed EEG, and then performed the electrical source imaging using a realistic head model and for the inverse solution accelerator. And we considered each individual structural MRI to measure to compute the head model and the forward model. So in order to reduce the dimensionality of the results, we parceled the brain in 82 regions of interest, and therefore, so we consider that the region that was the solution point that was in the center of each region was representative of the source activity of that region. So we ended up with 82 solution points, 82 voxels, and this is how we carried out the rest of the analysis. So after we performed the directed functional connectivity in the whole brain, using, as I mentioned already, Grant's causality methods, and then we chose to keep the analysis in the peak of the spike and in the frequency with maximal spectral power. And in order to summarize the directed functional connectivity results, we completed some measures, namely the summed out flow, the clustering coefficient, the between centrality and efficacy. So just a bit about the summed out flow. It's the sum of all outgoing values, and it reflects the driving importance of a region for the network. So the higher the summed out flow, the stronger the driving activity of other regions, so that region of other regions. And this is an illustrative case of a TLE patient with the presumed epileptogenic zone in the right mesial temporal. So you see that in the EEG, the maximal power was in the anterior temporal regions. So this is, I forgot to mention, this is the time and the peak of the spike is in the middle, so at 350 milliseconds. So the same for DSI, it was, so the sources were also in the mesial temporal region, sorry. So the amygdala, hippocampus, parahippocampal gyrus. And again, in the summed out flow, we see that in the peak of the spike, in the regions with highest activity are also in the mesial temporal, right mesial temporal. So this here I just represent some of the connections, so the strongest connections, and you see that these come from the mesial temporal regions towards other regions in the brain. So this is an illustrative case of an extra temporal lobe epilepsy patient with the presumed epileptogenic zone in the right basal frontal area. So here again, the maximal power in the EEG or skull potential is in the inferior frontal, in an inferior frontal electrode. And when we look at the electrical source imaging, the region with maximal activity was the orbital part of the inferior frontal cortex. And the same for the summed out flow. And the strongest connections were in between the frontal cortex, but also to other regions in the brain. So here we see the concordance of the several methods with the presumed epileptogenic zone. So overall, the ESI and the summed out flow had concordance of 76%. and also the efficiency, while between the centrality and close rate efficient had 70%. However, when we separated the TLE patients from the extra TLE patients, we saw that there was a much better performance for the TLE patients. So for the summed out flow, we had a 95% concordance. And while for the ETLE, the ESI had a 57% concordance. So there is a clear better epileptogenic zone localization in TLE than in extra TLE. And the ESI and connectivity measures were concordant in 32 out of the 34 patients. And we didn't see any significant differences between ESI and connectivity measures. So to conclude these results, the ESI and connectivity measures can reliably localize the epileptogenic zone from interictal spikes using routine clinical EEG, especially in temporal lobe epilepsy. And then we saw if there was an effect of the size of the lesion or the size of the resection and the overlap with the concordant regions. So we saw that there were larger regions and so being resected in TLE and also larger lesions. And therefore, in TLE, there was a larger percentage of source volume that was concordant. So there was a higher, and this might explain why there was a higher overlap with concordant regions in TLE. And it can be a potential bias for the TLE. Then we saw if the number of channels had also an effect, because so inside the low density category, we used 19 electrodes, 21, 29, 31, and 37. And we saw if using more or less electrodes had an effect, but we didn't see really any difference. And quite interesting, we saw that in the difficult cases, so patients with non-lesional MRI, the ESI and connectivity were concordant in all patients. So ESI and connectivity measures from routine clinical, so low density EEG recordings can localize the epileptogenic zone from interictal spikes in 95% of the TLE and 57% of the extra TLE patients. And there was a higher concordance with the presumed epileptogenic zone in TLE than in extra TLE. There was no added value. We didn't see any added value in the performance of connectivity measures versus ESI to localize the epileptogenic zone. But it's good to know that connectivity connectivity is reliable also in low density EEG, and this could be also useful for other study purposes. Namely, if we want to study the directed connections there, we have to look at the connectivity, not to the ESI. So there was no influence of the number of electrodes on the epileptogenic zone localization. And ESI and connectivity measures could be of a particular additional value in more difficult cases, such as patients that have a normal MRI, so a non-lesional MRI. So as a take-home message, the epileptogenic zone estimation with ESI and connectivity using low-density EEG could be applicable in clinical settings for helping in the localization of focal epilepsy. And unlike visual analysis, ESI and connectivity measures offer an objective assessment of the regions that play a key role in focal epileptic activity. And as future studies, it would be important to consider also patients with multiple foci and patients with poor operative outcomes, so that we can also compute the sensitivity and specificity. And also it would be very interesting to compare the connectivity results in low versus high density EG, so inside the same patient cohort. So thank you so much for your attention.
Thank you very much, Anna. That was a terrific presentation. We already have a few questions in line. Nana Kapanaje, the question is, do you have children as patients? What was the youngest age in your group?
We didn't have children in our group. The youngest, I think it was over 16 or 18 years old. I don't remember well, but there were no children, no.
Which actually brings along the other question that Jean Gottman asked. He realized that you answered his question, but regardless, it's very pertinent to Ashwin's question. Jean was asking whether the number of electrodes could influence the results. For example, if you use a medium density EEG with 40 or 50 electrodes, would that give you denser sampling in suspicious regions? And conversely, in kids that sometimes you have to use much lower number of electrodes, how would you foresee that the ability of a good ESI study to affect a very young pediatric EEG in terms of the localization?
So in this particular study, we actually saw, as I mentioned, the effect of using very low density, so 19, and studying and versus the 37. We didn't see a difference. Using 40 or 50 electrodes, I mean, it would be interesting to do that. The way I would think of doing that would be to consider high density recordings and to downsample. And then we could compare for several, for several number of electrodes, so considering from low densities from 19 to 200, that would be really interesting, and as I mentioned, would be quite an interesting question for our next study. For children, so again, what was I can't see the question for children.
Reducing further the number of electrodes, because sometimes in very young babies, for example, we have lower number of electrodes. Do you think that, is anybody doing studies with much lower number of electrodes to see what would be the value of this technique in localizing potential epileptogenic zones, particularly in kids who have more than one focus, which is sometimes...
I think that's a very interesting question. As far as I know, there are no studies, but as far as I know.
And the last question is from Ashwin Chari, great study. Have you used it in postoperative non-seizure-free patients to assess whether the ESI and or SAMT outflow is less concordant in these cases? So in patients after surgery who are not seizure-free, has this technique?
Yeah, so we haven't, that would be again also the next. So in this cohort, we just used patients with a very, outcome 1 or 2. So the next one would be, of course, to consider also patients that had a poor outcome to assess whether this would be also, I mean, if there would be a good sensitivity and specificity, but in this study we just consider patients with good outcome.
Great. Thank you so much, Anna. It was a pleasure hearing you, and all the best for the future. And I would like to continue and introduce with great pleasure one of the chief editors-in-chief of epileptic disorders, Alexia Zimanoglu, who will present the Educational Prize of Epileptic Disorders.
So, good morning, everybody. I saw that it was a big number of participants. It is a great pleasure for me, on behalf also of my co-editor-in-chief, Sador Brzezinski, to present the educational prize of the International League Against Epilepsy that comes with its educational journal, Epileptic Disorders. The choice for the nomination of Dr. Zongying was made on the basis of a selection of all the papers published in 2019. The procedure we have in epileptic disorders is that in a blind way, all the associate editors nominate up to 3 papers they consider the best educational papers. As you know, this is a difficult choice because education means everything. And in our case, it means, of course, the main message that a given paper produces or gives to the public, but also the way it is written, the way it provides valuable information to our colleagues about a given topic. And then on the basis of those proposals from all the associate editors, the editors-in-chief select the ones with that have the biggest number of votes, or the first one in this case. And then in agreement with the president of the league, the award is given to the best paper published in epileptic disorders. In our case, we are very proud to give this prize to Dr. Ying. As you can see from the slide in front of you, she has a rather international way of living. She was born in Beijing in China, graduated from the Medical University of Beijing, but then she did the rest of her training in Switzerland, where she obtained her Doctor of Medicine degree. After that, she moved to the United States, where she obtained her PhD in the field of neurosciences and completed her neurology and residency training. And then she moved to Cleveland, to the Epilepsy Center, where she trained in epilepsy, and then later on, she joined the staff. I don't need, I suppose, to present the team of the epilepsy team of the Cleveland Clinic. It is a very well-known team, a leader in the field. And the paper for which she received the prize of epileptic disorders is a paper on a comprehensive clinical, pathological, and genetic evaluation of bottom of sulcus focal cortical dysplasia in patients with difficult to localize focal epilepsy. As you can see, one of the figures of her paper also was honored by the cover page of the journal. It is a real pleasure for me to present to Dr. Ying the Epileptic Disorders Education Prize 2020 and ask her to make her presentation. I would also like to remind you that the questions and answers will be dealt in a minute by my co-editor Sandor, and it would be great if in the process of the talk you wish to ask your questions so that we can answer them and present them appropriately at the end of the talk. So Dr. Ying, please, the floor is for you. I will stop sharing my screen.
Thank you so much, Alexis, and thank you, ILAE President, and thank you, editors of Epileptic Disorders. It is such great honor to be selected to receive this award. I would like to thank all the co-authors for their important contribution to this work. I also want to thank specifically to Dr. Najim and Dr. Brunke for their driving force in the ILAE classification of focal cortical dysplasia. The next is a pre-recorded presentation, followed by Q&A live. I'm now presenting you the work that received Epileptic Disorders Educational Prize. The title of my presentation is Comprehensive Clinical, Pathological, and Genetic Evaluations of Bottom Sulcus Focal Cortical Dysplasia in patients with difficult to localize focal epilepsy. Focal cortical dysplasia are common histopathological lesions in children and adults with drug-resistant focal epilepsy. The classic FCD type 2 lesions have been well studied and recognized as a disease entity with MRI features, clinical, electrophysiological characteristics, histopathological findings, and surgical outcomes. A milestone in FCD research has identified mutation activating mTOR pathway in surgical brain specimens with histopathology proven FCD type 2. However, small FCD lesions located at the bottom sulcus, also called bottom sulcus FCD, are under-recognized. Both FCD present challenges in clinical practice. These small lesions are difficult to be visualized on neuroimaging. Ictal activities can be non-localizable on scalp EEG. Is both FCD within spectrum of FCD type 2 or separate disease entity? The aim of the study is to comprehensively evaluate both FCD in a group of patients with difficult to localize focal epilepsy, focusing on clinical information, MRI features, scalp video EEG data, intrinsic epileptogenicity with intracranial electrode recording, histopathological findings, surgical outcome, genetic findings. We retrospectively reviewed epilepsy center database from 2004 to 2014. 10 patients qualified the following criteria: drug-resistant focal epilepsy, single MRI lesion restricted to the bottom of sulcus, no previous epileptic surgery, no concomitant other diagnosis such as tuberous sclerosis or brain tumor, intracranial video EEG monitoring prior to surgery, post-operative MRI available to assess at the extent of the resection, histopathology slide available for post-hoc microscopic review. 4 patients were imaged with 3D scanner, 6 patients with 1-pound T scanner. Morphometric MRI analysis was available in 1 patient at the time of surgical evaluation, and it was retrospectively performed in 9 patients. Morphometric analysis program map was performed on T1 weighted MP rate sequence. Following non-invasive evaluation, all 10 patients were recommended for invasive video EEG monitoring for different reasons at that time. A few patients had non-localizing ictal EEG. 1 patient had atypical seizure semiology associated with the lesion. In a few patients, eloquent cortical areas had to be mapped out to define the surgical resection border. In 1 patient, both FCD was not accepted by a few members of the group. In 1 patient, PET findings were discordant with the lesion. 8 patients had implantation of subdural grid together with depth electrodes targeting both FCD. 1 patient had subdural grid without depth electrode. 1 patient had SEEG. For the genetic analysis, the targeted next-generation sequencing analysis of DNA was performed using formally fixed paraffin-embedded tissue available from 5 patients. The HE sections were reviewed. The regions with the highest content of abnormal cells were identified and marked on paraffin block. The tissue was punched out for DNA extraction. This area is shown at a high magnification here, and you can see the typical balloon cells here, balloon cell, and also dysmorphic neurons. Immunohistochemistry highlighted balloon cells with bimentin labeling and dysmorphic neurons with neurofilament protein labeling. There's also presence of protein markers for activated mTOR pathway labeled with TS6. Here's the MRI findings of both FCD. 6 lesions were located in the superior frontal sulcus, 1 lesion in the inferior frontal sulcus, 1 lesion in the central sulcus, 2 lesions are in the intraparietal sulcus. The both FCD lesions are best visible on FLAIR sequencing. The common MRI features is focal cortical thickening and the blurring of gray and white matter junction at the bottom of a sulcus. However, MRI post-processing with MAP made the lesions become evident and more easily to be visualized. The patient data showed age of epilepsy onset is from less than 1 year to 14 years. Age at surgery ranged from 13 years to 59 years. Each patient presented with stereotyped seizure semiology. It should be noted that superior frontal sulcus both lesions were identified in 6 patients. These 6 patients have variable seizure semiology. As for the ictal EEG, 2 patients had non-localizable ictal EEG. 1 patient had non-literalizing ictal EEG. 1 patient had ictal EEG patterns discordant with location of the lesion. Intracranial EEG data demonstrated that the both lesions are highly epileptogenic. Ictal EEG onset was mapped to the depth electrode contact localized in the both FCD or in the areas adjacent to the lesion. Here are the locations of both FCD lesions. And here are the code registration of depth electrode contact and their relation to the bottom sulcus. The contact at the bottom sulcus are labeled in red color. The both lesions have signature electrical discharge patterns. The red bar indicating ictal EEG onset. All EEG seizures transition from continuous pre-ictal repetitive spikes or rhythmic bursts of polyspike discharge. At the EEG onset, the electrical activities become tonic fast frequency discharge of variable voltage for durations. Surgical resection and outcome. The mean follow-up duration was 6 years, ranged from 2.5 years to 11 years. 3 patients had corticectomy. 7 patients had lesionectomy. 8 patients had seizure-free INGO class 1A. 1 patient did not return for follow-up. 1 patient, patient 10, had incomplete resection of the lesion. This patient did not become seizure-free, but 6 months later, this patient had a second resection of corticectomy with complete remove of the lesion. This patient has become seizure-free up to 6 years without any deficit. Histopathology findings. 6 patients had FCD type 2B. 3 patients had FCD type 2A. 1 patient had a small fraction of tissue with inconclusive pathology. Here's the overview of depth of sulcus. The dysmorphic neurons are concentrated at the bottom sulcus, are showing in the orange color. And this area was showing at a higher magnification. You can see the dysmorphic neurons are labeled with SMI 32. Accumulation of balloon cells are located in the underlying white matter, and this area is highlighted here. You can see the balloon cells are labeled with vimentin, showing in green color. Genetic findings. The lesion-enriched tissue samples from 5 patients that were microdissected harbored mean fraction dysplastic cells of 8.6%. The targeted next-generation sequencing analysis of panel of 166 mTOR, PIK3 8KT, and other epilepsy-related genes detected a frame shift insertion introducing a premature stop codon in DAPDC5 in 1 patient with FCD2A. DNA obtained from blood leukocyte was not available in retrospective analysis to confirm its germline origin. In conclusion, our result confirmed that both FCD can be classified into emerging spectrum of FCD ILAE type 2 mTORopathy, but with unique features, seizure onset at preschool or school age, mostly frontal localization, but can be at the bottom of any sulcus, stereotype seizures in each patient, but ictal EEG can be non-localizable, distinct MR features, but lesion can be easily missed. Both FCD may account for some MR negative cases. MRI post-processing should be used to guide the search for subtle both FCD. Highly intrinsic epileptogenic with signature intracranial EEG patterns, but invasive evaluation is not recommended unless there's a need for exactly delineate the resection borders or functional mapping. Favorable surgical outcome following complete resection of the lesion. Exclusivity of FCD type 2 with immunohistochemical or genetic evidence for possible activation of the mTOR pathway. Thank you very much.
I think Alex is muted, so I will take over. Hello, my name.
I activated it, but I was deactivated it. I just wanted to present Sandor and thank Dr. Ying. So Sandor, please take over the questions and answers of this talk.
Thank you so much, Dr. Ying, for this excellent presentation and the great paper. It has a great educational value because the readers can learn a lot about focal cortical dysplasias. So far, one question came, which is actually a congratulation from Nana Kaparnatse. And until further questions arrive, so let me just ask you a simple question. So you mentioned yourself in the paper that the number is relatively low, so there's a need for larger studies. Are you planning or are you conducting perhaps such a study?
Yeah, actually, this research will continue in a prospective manner. Sorry, I couldn't quite hear. And also, I think in the future, you know, the whole epileptic society should perform large number of patients in multi-centers, you know, to further bridging our knowledge gap of the genetic etiology of focal cortical dysplasia, and to clarify if the mutation variant DAPDC5 is causal for epilepsy, or epilepsy is second to the FCD type 2 lesion.
Yes. Thank you. Several more congratulations arrived, and here's a question. Is there any interictal marker in the scalp EEG that would be an indication of bottom of sulcus focal cortical dysplasia?
In our patient, there is a very rare interictal discharge. So the reason is that the lesion is small and also located in the bottom sulcus. So it's difficult for scalp EEG to record any interictal epileptiform discharges.
And then a question from Dr. Shangakman. Do you sometimes see seizure onset pattern outside the visible lesion?
Yes. So in one patient had ictal patterns outside the lesion, that could be explained, probably the subcortical lung fiber tract was propagated to the more distant brain area. So you see the ictal discharge discordant with location of the lesion.
Well, no more questions, and we are a little bit behind the schedule. So thank you so much, Dr. Ying. And now it's my great pleasure to introduce the next speaker, Professor Michael Sperling, the editor-in-chief of Epilepsia.
Thank you very much, Dr. Benischke. This is the last talk of the day that I will be giving for those of you, because I know we're running a tiny bit late. It only lasts about 11 minutes. It's a little shorter, so we should finish close to on time. This is a pre-recorded talk, and we'll get it started now. Thank you.
Hello, my name is Michael Sperling. I'm a professor of neurology at Thomas Jefferson University in Philadelphia and co-editor-in-chief of Epilepsia. I'm going to be giving a brief talk today, and the topic of my talk is Publish, Not Perish. This will be a brief discussion about publishing in academic journals. And let us now start the talk. Why do we publish in academic journals? For obvious reasons. We want to report what new knowledge we have gained. We want to foster education. And the worst reason, but frankly, it's one of the things that faces many of us in academics, is that it's required for promotion. If you want to be promoted, they look for publications, and that's the fear of perishing. And what can we do to optimize your chance of successfully publishing? There are different kinds of publications that one can do. There can be original scientific contributions, review articles, which largely have an educational focus, and also a scientific educational article that has a primary educational focus but applies the scientific method, and all of these are acceptable. We publish for the intellectual satisfaction of doing so, and I think it's important to try to enjoy the writing while you're doing it. Find topics that excite you and interest you, and then you'll do well. And obviously, and like everything else that we do in professional life, we want to do it well. We want to do as best as we can. We want to do a good job. The two major types of research I'll speak about here are original research and review articles. Original research presents new information of interest to readers, and that is, I think, the key. That is the point. You want to present new information that's interesting to readers, that's suitable and appropriate for readers. The report that you write should advance knowledge, either fundamental or practical, or something in between, and ideally have an impact on the field, either theoretically or again, or practically. The topic should be pertinent to the journal, and the journal title often gives you a clue as to what the journal is interested in. If it's a broad neurology or neuroscience journal, or like Epilepsia, a focused subspecialty journal. I recently had to turn away a paper that was about ADHD. I'm sure it was a fine paper, but it was not the topic for our journal. Since people read to learn new things, you want something that's reasonably new, or a new take, a new insight. The fifth report of the identical finding with the identical conclusions is not new, and it's not terribly useful, and journals are mostly not going to be interested in doing that, at least not the more prestigious journals. The world's largest case series might be nice to have, but again, it should provide some new knowledge. Size is not critical. It's what insights are gained from it. And obscure or rare observations may be important. Usually they're not, but they may be. So for example, in the current age of COVID-19, we will publish things that we might not consider about other conditions because the disease is so new that the world really needs information, and the scientists and physicians need information. When HIV came out, it was the same thing. When you're publishing a paper, you should have a primary research question, and there should be a clear testable hypothesis. And I put in most cases, certain epidemiologic studies might not have a testable hypothesis. It's examining incidence and prevalence and things of that nature, which are equally important, for example, but ideally the typical paper does have some sort of hypothesis, and there needs to be a question and a reason to ask the question. You have to avoid fishing expeditions. We see a lot of imaging papers, for example, where people compare what some aspect of MRI shows in one group of patients versus another. Is the white matter thicker or thinner in people with childhood absence epilepsy than juvenile absence epilepsy? Maybe it is, maybe it isn't, but tell us why you want to do this. Why does it matter? What does it learn? Simply having a testable hypothesis is not sufficient. There needs to be a sensible, plausible reason to look at this question. How do we assess the information of interest that we publish? Well, we look at it in two ways. Number one, does it attract publicity? Are people interested in it? So there's a score called the Altometric score, and this is put together from a variety of criteria. There are peer reviews on Faculty of 1,000, citations in Wikipedia, published public policy documents, discussions and research blogs, mainstream media coverage, bookmarks and reference managers, mentions in social media, and a variety of other ways. And Altometrics puts this together, and it tells us which papers got interest, which provided interest from people in a variety of formats. That tells us what topics are the world in general is interested in, and potentially our audience. Citation index obviously plays a role too, or the impact factor is another way of looking at it. Are the papers that we're publishing cited? If they are, it tells us we're looking at papers and choosing ones that people generally find interesting and interesting enough to cite when they're writing new papers. Citation index and the impact factor are methods of quality of a journal, and partly the quality reflects, are you publishing what other people are interested in and helps move the field forward? If other people cite your work, it must have made a difference to a certain extent. And when you're thinking about submitting, it's useful to see if the journal you're submitting to has published paper on the topic that you're choosing. If they haven't at all, and there have been many papers on this topic in the past, perhaps the editors are not interested in that topic. This is an example for epilepsia, citations published on a website. The reference is below, and it shows how the articles published in epilepsia over the past 2 decades have gradually gotten more and more interesting to other people who write. They found them worthy of citation. And you can see it just continues to rise even in the past half dozen years. So this is one way of a journal editor to look and see whether or not she or he is publishing in areas that people find important and useful. Some papers don't get a lot of citations and they're still quite good, and they may be important. There may not be a lot of people working in the field, and that's perfectly fine as well. So we don't even consider how a particular article will affect our impact factor when making a decision. It's the quality. Is it good work? Does it move the field forward? And is it within our area of specialization? That's all that counts. Review articles are the other major type that we do, and these can be commentaries or reviews. They should educate, provoke thought, and hopefully foster new research in an area. Ideally, a good review article raises issues that have yet to be addressed that people might do it. They should be thoughtful, not a mile wide and an inch deep, as we recently received on one paper from a very perceptive reviewer. It was a solid review article, but as the reviewer said, it covered a lot of territory, but it didn't go into things in great depth. You want it well-focused, and most importantly, to critically appraise the cited research. What are the good things about it? What are the bad things about it? And synthesize it. That's what we look for in reviews. We want reviews that aren't identical to what everybody else has written in the last few years. When we see a review, we want to know, what does this add to the literature? Is it something different? Does it provide new information and new insights? The paper should be understandable to the journal audience. If it's highly technical, make it so it's comprehensible by people like me, who might be reasonably intelligent but not strongest in basic mathematics or physics or some other areas. The English should be fluent and natural. No matter how good your English is, if you're not a native speaker, it can't hurt to have a native English speaker proof it for syntax. And I would keep in mind that when thinking about papers, that scientific advances are usually incremental. They don't have to shake the world. They simply have to be interesting and good, and hopefully provide insight, provide education, generate some light, not only heat. The structure is critical to the success of the submission. You want a clear introduction that tells us why you are doing this. You don't need to review the field. You don't need to tell us about the history of epilepsy and that it's common. We all know that already. What's the point of your work? What's your question, and why is your question important? Have the methods be precise, concise, clear enough so others could replicate your work, and most importantly, consult a statistician if you're using statistics. Make sure it's done properly. Whenever possible, have a control group. Lack of a control group or lack of a suitable control group are one of the most common reasons for papers not being accepted. You want to present the results clearly, logically, and the most important things early on. Don't bury it in the middle. Let us know what your main message is early in the course of your results. And then in the discussion, discuss your results, critique your data, interpret them in light of what's been known before, and then tell us what new questions your research raises. And I would advise everyone to do what I do and have friends and colleagues read your paper and critique them as strongly as possible before you send it into a journal. Get all the criticisms before you send it in, and you enhance your chances of success. Where are we going to in the future? Are we moving away from traditional papers? Yes and no. No, quality matters. There are lots of forums that people can publish things on if they want. There are journals called predatory journals. There are lots of journals that are open access. You pay some money, your paper goes on. You have a clue that it has no meaningful peer review and it's up right away. But good journals, journals that count for promotion, journals that really make a difference in the field have not changed. Quality matters. Quality is quite important. Are we moving away in other respects? Yes, new formats are coming online, various platforms, different means of presenting data. This whole symposium is being done in a way that we typically would not have done. This symposium was originally supposed to have been done live at the International Epilepsy Congress, or the European Congress, that is, in Geneva next month. Life changes, we change. And I think we'll see how this continues. The whole issue of open access is probably the most difficult and challenging thing that is facing the publishing industry now and over the next number of years, and we'll have to see how that goes. Thank you very much for your attention, and very glad that you were able to join us. Goodbye.
Hello, everyone. We'll take a couple of questions and then finish. The first question I'll read is, what's the opinion about publishing a preprint manuscript on bioRxiv or a similar one? Are we allowed to present our data before submitting manuscripts? This is an excellent question. I should have included it in my talk. And thank you for raising it, because that was one of the things I was going to say afterwards. In short, the world is moving this way. It started in physics. It has moved throughout science, and now many reputable journals, ours included, allow people to put papers on preprint servers such as bioRxiv and others. Keep in mind that the old idea of embargo of information is beginning to die, and I think it's a good thing that that's happening, actually. So no problems with preprint servers whatsoever for us and for many other journals. And then Dr. Gottman asked, what is the value of pre-registering a hypothesis and method for a study? So for pre-registering, I assume you're talking about posting it on the government website. I mean, there's a big advantage of doing that, of having something set in advance. You've laid it out. You've forced yourself to use proper methods. You've defined your question and hypothesis in advance. You have defined your statistics in advance. So it forces you really to do the research project properly. So clinicaltrials.gov for various projects is an excellent idea for posting. Are there any other questions? None being typed. Since we are 4 minutes late, I think I'll take this opportunity to then end the meeting. I want to thank everybody for attending on behalf of all of the speakers and the organizers. We want to offer special thanks to Priscilla Schisler, Dennis McAvoy, and Finola Quinn, who helped organize and plan this. And we look forward to seeing you all in person at some time, but in the interim, online symposia, I think, will continue, and they're probably here to stay. Goodbye.